specific things that we look for on the hemodynamic pressure screen that will assist us in identifying, yes, this is hypertrophic, or yes, this is restrictive. So dilated cardiomyopathy has a lot of similarities to do with congestive heart failure in regards to pressures increasing, DPDTs decreasing, enlargement of the cardiac shadow on the x-ray. But today we're going to be talking about the two that have a tendency to cause people problems on the board exams. So we're going to start off with hypertrophic obstructive cardiomyopathy. Which is usually abbreviated HOC. Now, remember when we're talking about the cardiomyopathies, we're not really speaking about the compensatory mechanisms that cause hypertrophy. What we mean by that is when we're talking about true cardiomyopathies, we're not talking about the cardiomyopathy or the hypertrophy that occurs with hypertension or aortic or pulmonic valve stenosis. That is considered a compensatory mechanism and not a real cardiomyopathy. Now it can cause problems still, but there are problems associated with another disease process. When we're talking about cardiomyopathies, we're talking about diseases that affect the muscle itself more directly and are not considered compensatory mechanisms or compensatory problems. So yes, you can have a hypertrophied heart due to valve disease or stenosis. You can have hypertrophy due to hypertension, pulmonic or systemic. But we really don't classify those as cardiomyopathies. We classify those as hypertrophied muscle due to a secondary cause. But hypertrophic cardiomyopathy, especially the obstructive type, again, is a genetic issue. Genetic mediated, which means you are born with this gene, and when this gene activates, it's going to cause unusual, non-compensatory hypertrophy or thickening. Non-compensatory means it's not reacting to something in the body. It's just going to start to hypertrophy abnormally on its own. Genetic mediated. It's just going to trigger. And with this type of obstructive cardiomyopathy, we usually see hypertrophy of a single wall. What's the most common wall that hypertrophies? The septal wall. After the septal wall, then it's usually the apical and free walls, but it is the septal wall that is the most common. Okay, so the septal wall is the most common wall that is affected by this. Now there are a couple of things that we become concerned with the hypertrophic obstructive cardiomyopathy. The abnormal myocytes increase the risk for SCD. What does SCD stand for? Sudden cardiac death. It increases the risk for sudden cardiac death through a reentry phenomenon. That thick muscle tissue, those abnormal tissues conduct electricity in an abnormal way because they're so hypertrophied. Because of the difficulty will be to transmit through those tissues, we have an increased risk for sudden cardiac death. So that is one of our concerns. People with hypertrophic cardiomyopathy are at increased risk for sudden cardiac death, which is another reason why for a while we attempted to have every athlete have a very limited echocardiogram done, just to rule this out. Insurance has decided not to do that anymore. They won't do that anymore because the number of people who are born with hypertrophic cardiomyopathy or with a genetic disease is pretty small. So you could scan thousands of people and maybe only find one. And so it's not really cost effective. However, to that one, it could be quite significant. So when it comes to sudden cardiac death, we've tried a couple of different approaches because sudden cardiac death is the leading cause of death of athletes. And so sudden cardiac death can be triggered by electrical abnormalities and can be triggered by hypertrophic cardiomyopathies. And so we've tried doing EKGs on athletes and ultrasounds on athletes, and the insurance companies are just like, we're not finding enough to make it worthwhile. Although if you're the one that we find, obviously that changes. But it is still something to keep in mind, that these are things that can cause, especially our young athletes, some difficulties. So that's one of the things that we're worried about is sudden cardiac death. The second thing that we are worried about The other thing we're worried about with hypertrophic cardiomyopathy is the outflow tract obstruction. The muscle tissue becoming so thick that when it contracts, it will actually impede and block blood flow from coming out of the ventricle. If we draw out the heart, we can kind of see, hopefully this will pick up. If we draw out the heart, so this is what a hypertrophic septum would look like. Very thick septal muscle tissue. And right here is the outflow tract to the aorta. It's kind of hidden behind this little area right here is my aortic outflow tract is. So when the ventricle contracts, what happens is this muscle will contract and seal off the lower portion of the ventricle from being able to eject. The upper portion of the ventricle will eject blood out normally, but the blood in this lower chamber, will be blocked when this ventricle contracts because there is this significant impediment. And that's why we call it obstructive cardiomyopathy. The muscle has grown into the outflow tract, has covered the outflow tract, and will obstruct blood from exiting every time the ventricle contracts. And so that is rather problematic. Now, what is the best way to diagnose this probably? Echo. Echo would be the best way to, echocardiography would be the best way to diagnose this. And why would echo be the best way to diagnose this? You can actually see it. Does anyone have a guess of which view on echocardiogram would be the best to look for the obstructive cardiomyopathy? The apical forechamber. Very good. That's where we would see this thickened wall muscle, would be the apical forechamber. Now, in the cath lab, we can validate that and we can actually find specific evidence that a patient has obstructive cardiomyopathy as well. So let's talk about what we find hemodynamically. let's talk about the hemodynamic changes associated with HOCM. What are some problems that we find when a patient has obstructive cardiomyopathy? There are 3 things that we look for, and then I'm going to switch to the PowerPoint that goes through these 3 factors, okay? One is pulsus bispherians. The second one is an intraventricular gradient. The third one is what we call Brockenbrough's response. So these are 3 things that we look for if we think the patient has hypertrophic obstructive cardiomyopathy, HOCM. Now, if you just have hypertrophic cardiomyopathy, if it's not the obstructive kind, then we wouldn't find these things. So if the free wall was hypertrophied, if the apical wall was hypertrophied, you would not have these 3 findings. These 3 findings are specific to the obstructive form of cardiomyopathy, where the outflow tract is kind of pinched. So pulsus bispherians we've talked about before. What does that term mean? We've talked about this briefly before.
The pressure is changes up and down every other beat.
No, that's pulsus alternans, and that's what we see with heart failure. So pulsus alternans is when one beat is strong, one beat is weak, one beat is strong, one beat is weak. That is the key finding for dilated cardiomyopathy and heart failure. Okay, so that's not this. A good guess, good recall. Pulsus bispherians. Well, bi means what? 2. Okay. So pulsus bispherians means that each aortic pressure has 2 systolic beats. There's 2 systolic beats per aortic pressure. So what we will see on the screen is this. We will have 2 systolic beats and 1 dicrotic notch.
What do you call the thing between systolic?
The 2 systolic beats?
Yeah, what do you call
That's just the valley.
Okay.
You have 2 systolic beats and 1 dicrotic notch. This is not 2 contractions. We did not have 2 contractions here. This is all from 1 ventricular contraction. So you have 2 systolic beats and 1 dicrotic notch per ventricular contraction. This is actually what the recording looks like. 2 systolic beats and 1 dicrotic notch per ventricular contraction. Matter of fact, you can actually feel it on the pulse as well. When you're feeling it on the pulse, you'll feel you'll actually feel two quick pulses for every cardiac beat. So pulsus bispherians. And we only see this with HOCM. This is the only pathology that you see it with. Nothing else. You don't see it with any. So if you see pulsus bispherians, you say, I know what this is. This is HOCM. So the question is, what causes this? Why do I have 2 beats for every 1 contraction? Well, it has to do back with this picture that we drew here. Just a moment ago. So, when the ventricle is triggered to beat, the entire ventricle contracts at once. However, this septal wall contracts faster and more vigorously than the rest of the heart muscle does because it is so massive, so hypertrophic. So when the left ventricle contracts, the upper portion of the blood will be pushed out. But now there is an obstruction to the lower portion of the ventricle. So this part of the ventricle still continues to contract, trying to overcome what?
The resistance.
It has to overcome this resistance. So that first bump that you see in the aortic pressure waveform is the proximal segment contracting and pushing blood out. The second bump is the continued struggle of the lower chamber continuing to contract to push the blood out. So you actually have 2 ejections out of the ventricle per 1 beat. The first ejection occurs very early as the hypertrophic proximal segment pushes blood out, and then that second bump that we see, the second systolic bump, occurs as this area of the ventricle continues to try to contract to overcome the narrowing here and push blood out. So we actually see 2 systolic ejections per 1 contraction. So yes, we have 1 contraction, but 2 systolic ejections. Pulsus bispharinans. It is only seen in hypertrophic obstructive cardiomyopathy. That's it, only seen there. Now the next thing that we see is something called an an intraventricular gradient. Intra means within the ventricle. Intraventricular gradient. What does a gradient mean? Difference in pressure, that's right. So, in a normal heart, if I have a catheter, a pigtail catheter, if I have a pigtail catheter in my ventricle, whether I am proximal or distal in my ventricle, which should the pressure be?
Same.
It should be the same. Whether I'm proximal or distal in that ventricle, whether I'm high or low in that ventricle, if I pull the pigtail up here, the pressure up here should be the same as the pressure down here in a ventricle. Okay, so they should be exactly the same. However, if I have hypertrophic cardiomyopathy, so there's my hypertrophic cardiomyopathy. If I put a pigtail catheter down here, will that pressure be higher or lower than when I put the pigtail catheter up here?
Higher.
It'll be higher. Why will the lower part of the ventricle be higher than the upper part of the ventricle?
More volume.
Not volume.
Chamber size.
Chamber size.
Chamber size, and what am I pushing against?
Resistance.
I'm pushing against a resistance, which means in reality, this area of the ventricle has to produce more pressure than this area does. This area will have a lower pressure than this area will have because of this resistance. Should I have a difference in pressure in my ventricle?
No.
No. So what happens with intraventricular gradient is as I pull the when I pull that pigtail catheter backwards, I will see a drop or a decrease in ventricular systolic pressures. I'll show you that in just a second. As the catheter is pulled back from the ventricular apex, the systolic pressures will drop. So what I would have is as I started to pull it back and I get past the obstruction, as I continue to pull back into the aorta, I would actually have a gradient within the ventricle itself. Systolic pressure would drop. Matter of fact, this is exactly what it looks like here. So we pull back across the ventricle, and here is the ventricular pressure at the apex. And as I pulled across through the apex, what happened to my systolic pressures? They dropped. That is a sign of HOCM, that is hypertrophic obstructive cardiomyopathy, intraventricular pressure gradient, or what we call just intraventricular pressure gradient. The systolic pressure drops as we pull the catheter slowly through. We always start in the apex, and we pull the catheter from the apex to the proximal segment of the ventricle, just underneath the aortic valve, and my pressures will drop. And as I continue to pull into the aortic pressure will equal my ventricular pressure. The aortic pressure will equal my ventricular pressure, or my lowest ventricular pressure.
Is it called the lowest?
The lowest ventricular pressure will be what my aortic pressure will equal. Because this is pushing against the blocked ventricle, not against the aorta. This is pushing only against the aorta. So my aortic pressure is represented, will be equal to the lower ventricular pressure. And that is called the intraventricular gradient. Are we good so far? Okay. Now, the last one is broken Burroughs response. And the only way I can explain it is to show you. So, broken Burroughs response can only be detected if I have a pressure being recorded in the aorta and the LV at the same time. So this requires me to have simultaneous pressures recorded across that aortic valve. So that first brings us to an interesting question. How do we record simultaneous LV and aortic pressures? There's about 3 ways that we can do this. Now, what we can eliminate is the pullback. The pullback technique that we use most of the time to compare ventricles to aorta, that pullback technique that's here in left heart caths all the time, that allow us to compare LV and aortic pressures, will not work for this, because I don't want a pullback. I want a simultaneous, which means I'm getting aortic pressures and LV pressures at the exact same time. There are 3 ways to do this. One way we can do this is we can use, by the way, we will always need to have 2, what's I'm looking for, transducers to do this. If you want to measure things at the same time, you have to have 2 transducers. One is we hook up a transducer to the catheter that's in the LV, and we hook up a transducer to the sheath in the artery, where our access is. Couple of things that we need to make sure is that the sheath must be one French size larger than the catheter. Especially if you have two, but at least one French size catheter larger. Why do I have to have the sheath being larger than the catheter itself in order to do this? In order for this to work, the sheath has to be at least one French size larger than the catheter itself. Why?
Are you using two catheters?
Nope. One catheter is in the LV and the other transducer is going to be hooked up to my sheath.
If they're the same French size, wouldn't they be recording the same, like, wouldn't it end up recording what the catheter is?
No. Because where's my sheath?
In the access site?
Yeah. Could I record the ventricle from down here?
Oh, no.
Nope. So why do they have to be different sizes? So the catheter is going to record the LV, the sheath is going to record which pressure? The artery, it's going to reflect the artery. Remember, in your body, the arterial pressure is the same throughout your body, technically. So why do I have to have the sheath one French size larger than the sheath for this to work?
Does it have to do anything with the vacuum part, like when you have the same size, it might just?
Not the vacuum part. No, it's not a vacuum problem.
Does it have to do with like detecting a gradient or?
Well, that's why we have to use it, but why? Let me ask you this way.
Radius-
If you have a, go ahead.
I would say like the radius of the catheter might have to do with the pressure and volume.
Close, you're getting closer.
This French size represents the inner lumen of the French size, right?
Yeah,
Okay, so. I don't.
well, you're on the right
I still
track.
don't have all of the information.
No, you have all the information. You do. A 7 French sheath can fit a what?
Anything.
7 French catheter, right? If the 7 French catheter goes into the 7 French sheath, is there any room in there to measure blood or pressure?
Oh, it's too tight.
It plugs up the hole, so I can't get any pressure into that sheath. The sheath wouldn't record anything because the catheter takes up the entire lumen. So if I use a slightly smaller, do I have anything smaller than my pen? No. Give me a second here. Yes. If I use a slightly smaller catheter into that sheath, I have room. Pressure has to have room to transmit. So if this whole sheath was plugged up with my catheter, could any pressure get up to that transducer? No. So I have to have a smaller catheter compared to the sheath so that pressure can push up towards that transducer to be recorded. I have to have space. So the catheter has to be at least 1 French size smaller so that the pressure can move around the catheter up to my sheath. Otherwise, there's no room for that blood or that water to move. Remember, we have to have a column of fluid theory. So if the catheter is hooked up and is plugging up, I don't have a column of fluid anymore. I have a catheter, and catheters do not conduct pressure.
I don't understand where you're connecting the transducers. I know that the normal transducer, how that's connected to the manifold, but I don't understand how you're connecting another one.
You mean onto the sheath? So where does the transducer connect to the catheter?
At the hub.
At the hub, right?
Okay,
What do you have on the sheath that you can connect the manifold to?
The side port.
The side port.
So what does this look like? I mean, I know the transducer, we have the cord and we have the tube going up
Yeah.
to the transducer.
And so one hooks
Where
into the
does
side, one hooks up to the side port of the
To
sheath,
the end of the catheter.
and the other manifold hooks up to the catheter itself.
So you're using two manifolds?
Well, two
Is it
transducers at
manifolds?
least.
So you can have two transducers on one manifold?
No, you don't have to have a manifold at all, you can just have a transducer hooked up.
Oh,
So,
okay.
you can have a manifold hooked up to it too, it doesn't really matter. So, we have one hook up to the sheath, one hook up to the catheter, and the catheter has to be one size larger. Now, there is a problem with this connection, there is a problem with this process. The first one is that there is a time delay between the two pressures if we do this process. So if I draw out my little guy here, and let's put the sheath in the femoral artery. So here's my sheath, hooked up to one transducer. And then I also have a catheter to my heart, hooked up to another transducer. When the heart contracts, ideally we would record the pressures at the exact same time, except it won't happen in this case. Who will record the pressure first as the heart contracts?
The one in the LV.
The one in the ventricle, because it's right there. It's going to take some time for that pressure to come all the way back to the femoral sheath. So they're not going to be lined up perfectly. So you'll have the ventricular pressure waveform, and there's going to be a slight delay because of that distance. What was that?
Could you do extension?
You'd have to have about a 3-foot extension onto this transducer because that's about how far away it is. So that's not a good idea, not permanent. So all you do is with your computer, what can you do to your pressures?
Move them.
You can shift, using the computer, you can shift them. Okay, so that's one way to do it. There is another problem with this, but we'll come back to that problem in a second. Okay, this is not the best answer because there's another problem associated with it, but we'll come back to that in a moment. The second way we can do this you can have two catheters, one in the LV and one above the aortic valve. So this is my ventricle, here's my aortic valve. So in this case, I have a catheter that's in my ventricle itself, and I have a catheter in my aorta. So I have two catheters inside my body at the same time. Now, the benefit of this is I'm right at the aortic valve. This is far away, so this is going to create some problems being so far away. This is going to create some issues for us. But this is right above the aortic valve, so that when the ventricle contracts, the LV and the aorta and the catheter and the aorta are going to record pressures at almost the exact same time. What are some problems with this approach? You're going to have to use a big sheath, or how many access sites? Two. So you either have a large sheath that you can fit two catheters through, or you have two different access sites. Both of those are gonna increase what risk? Not infection. Bleeding. It's gonna increase the bleeding risk. A larger sheath is gonna increase the bleeding risk, and if you have two sheaths at the same time, you can increase the bleeding risk. The other issue that we have is there's still going to be a time delay. And the reason for that is both of these catheters are going to be 110 centimeters long. This gets the pressure slightly before this one does, and this has to transmit at 110 centimeters. This has to transmit 110 centimeters. Which one's going to make it to the waveform or to the transducer first? The one that's in the ventricle is going to make it first. So are they going to line up perfectly? No. It's going to be more accurate though than the other side, okay? Than this process. It's going to be more accurate than this process. But we have increased risk of bleeding.
Why would the LV one be first?
Because it receives the pressure first.
Okay.
So how can I do this? I can't really give an example of this. So as this starts to transmit right away, this will transmit it once that pressure hits the aorta. They both have to go the same distance. So this one starts earlier, it has to go the same distance. This one starts later, it has to go the same distance. This will transmit, it takes longer to transmit. So again, we're still gonna have the time delay, but it's not gonna be as bad. It's not gonna be as horrible of a time delay. It'll just be a few seconds off. Our third possibility is a dual lumen pigtail catheter. And that is a pigtail catheter with how many lumens in it? Two. The dual lumen pigtail catheter has 2 points of pressure. So this lumen right here ends right about there and has an opening there. And the other lumen goes all the way to the distal tip. So that way, how many catheters do I have to use? One. I have one catheter. And when I put it into my LV, here's my mitral valve. Here's my aortic valve. When I put it into my LV, this will measure my LV pressure and this will measure my aortic pressure, but I have one catheter. Which one do you think is more accurate out of these 3 methods? The dual lumen. With a pullback, I cannot record them at the same time. I record the LV and then the aorta when we pull back. But these 3 methods allow me to measure the aorta and LV at the same time with varying levels of success. This is the least accurate, the next most accurate, and the most accurate. We will very rarely use a dual lumen pigtail catheter unless it's really warranted. Does anyone want to take a guess why that is?
It's too big.
It's not too big. Good guess. It's a really stupid reason.
Costly.
One dual lumen pigtail catheter is the cost of 2 catheters. Technically they're very expensive. So it's actually cheaper to do the two catheters. Or to do, the cheapest is this method. This is the cheapest method because you have to have a sheath already. You have to have a catheter. This is the cheapest method. So what are we doing? Why did I go through this? Well, for the third method that we have for identifying HOCM, you need to be able to measure the aorta and the LV pressure simultaneously. And it's called the Brockenborough response, or Brockenborough response. Now, the Brockenborough response has to deal with the idea of Frank Starling's law, and we're going to trick the heart. Okay? So, what happens is, and it's very hard to detect this, you can't really plan on this, but we try anyways. So before we do the pullback or anything like that, it looks like I have what problem right here in my heart? I have a gradient there. So normally what pathology would that be? What type of stenosis? Yeah, sorry, that'd be aortic stenosis. When my LV and my aortic pressures don't match up, that's usually a sign of aortic stenosis. Well, we already did something on this patient. We already did this. So I don't have aortic stenosis. I did the slow pullback. So what did the slow pullback prove that I had? Obstructive. So the reason why it looks like it's aortic stenosis is this catheter is in the apex. This is in the aorta. Between the apex and the aorta, I have that big bulge in my ventricle, okay? So it looks like I have aortic stenosis, but if I did a slow pullback, it would turn out that the proximal LV would be equal to this aortic pressure. But nonetheless, what we're going to try to do is we're going to try to create a PVC. Now, what is a PVC? Premature ventricular complex. What does that mean happened though? So I have a premature ventricular complex, but what does that mean occurred? What happened?
Ventricle contracted before it was supposed to, or just erratically?
That's right, the ventricle contracted earlier than we wanted it to. Premature ventricular complex means that the ventricle was triggered to contract before the next beat. Now, because of that, what was the filling of that ventricle like? Since it contracted early, did it get as full as it should have been?
No.
So that contraction is going to be very weak because of the Frank Starling's law. Since the contraction occurred early, since the impulse occurred early, the contraction is going to be weak. And so here's my PVC right here. So here's my normal beat, here's my PVC, and what do you notice about the PVC pressure? It should go down. Did it?
Yes.
Yes. Yeah, so the PVC pressure went down. Now then, after a PVC, we always have a pause. It's called a compensatory pause. After a PVC, it's not with every premature complex, but after a ventricular premature complex, after a PVC, we don't see it with PACs, we don't always see it with PJCs, but after a PVC, the heart pauses for a second and goes, what the heck just happened? We have this pause. Now, during this pause, what is the ventricle doing? It's filling. So during the pause, we talked about this is one of the reasons why we don't do an LV gram right after a PVC, because what does the heart do on a beat after the PVC? It compensates and overfills, which means the next contraction should be less than, equal to, or better than normal. Better than normal. So we should see what happened to all of the pressures on the beat after the PVC. They all should increase. The ventricle pressure should increase because it's super filled, and the aortic pressure should increase because it's getting more blood, right? That's what should happen. However, when you have HOCM, what occurs is we have what we expected to happen at the PVC, but after the PVC, what happened to the ventricular pressure? It went up, that's what we expected. What happened to the aortic pressure?
Went down.
It went down or didn't change compared to the PVC. Is it as good as normal?
No.
No. So the reason this happens is when the ventricle with that big, thick septal wall contracts, it totally closes off the aortic valve. So can we get as much blood out of the aorta anymore? No, since it overfilled, that strong contraction after that actually occludes the aortic valve. So after a PVC, the aortic pressure drops. What should the aortic pressure do after a PVC? It should increase. So it does the opposite after the LV pressure will do what we expect it to do. It'll go up. But the aortic pressure will go down.
So with a higher EP after that, will the next ventricular contraction be also quite big?
No, because this event, a little bit, maybe a slight bit, but not as much. Not as much. There'll be a slight increase, but not as much as before, because we're only talking about that lower part. So it's not the entire ventricle that didn't empty.
Okay.
So the broken burrow response is after a PVC, the aortic pressure decreases with the next contraction. And that is a sign of HOCM. We only see this in HOCM. So there are three things we only see in HOCM. Pulses by spherins, intraventricular gradient, and broken burrow response. Those three factors are what we look for during a right heart cath if we believe somebody has a hypertrophic cardiomyopathy. Those are the three factors that we look for. So with dilated cardiomyopathy, we're looking for increased EDP, increased diastolic pressures, decreased DPDT, and pulsus alternans. Every other beat is strong. With hypertrophic obstructive cardiomyopathy, what we look for is intraventricular gradient, pulses by spherins, and the broken burrows response. And then we want to talk about restrictive cardiomyopathy. But let's take a break first. We'll take a break and we'll talk about the two basic changes we look for in restrictive cardiomyopathy. Mm-hmm.
So you say the aortic pressure drop in the HOCM after the PVC because the contract too strong and
Yep.
then close up the aortic valve?
Yep.
And when you close the aortic valve, nothing measures the pressure drop? That's right?
Just very little blood gets out.
Oh,
Because you have something measuring the aorta, it's just very little blood gets out.
okay.
Okay. So now we get to restricted cardiomyopathy, the rarest of the cardiomyopathies. So dilated cardiomyopathy has lots of things that can cause it. If you remember the list of things that can cause dilated cardiomyopathy, it's everything from viral to genetic to pregnancies to toxins to medications to, there's lots that can cause and damage the myocardium. And that's not even adding to the non-dilated cardiomyopathy enlargements that are caused by MIs. Remember, that is separate. And that's called, remember when your heart enlarges because of damage to it, we call it remodeling. Dilated cardiomyopathy is a change in the muscle tissue that causes it to dilate abnormally. Then we talked about hypertrophic, and hypertrophic is all purely genetic. We don't include hypertrophic due to compensatory mechanisms because they usually don't get bad enough to create HOCM or sudden death. The third class, restrictive, has a few more causes, but it's not as blatant as causes, or not as large a number of causes as dilated. With restrictive cardiomyopathy, there is a genetic or an autoimmune disorder, such as amyloidosis, sarcoidosis, hemochromatosis. These are genetic issues that cause your body to produce, or autoimmune issues that cause the bodies to produce more than what it needs of different proteins and substances. Also with restricted cardiomyopathy, we have the risk associated with radiation therapy, especially radiation therapy to the chest can cause restricted cardiomyopathy. However, it's the least common cause. The genetic predisposition to this, the amyloidosis, the sarcoidosis, the hemochromatosis, all of those are less common and are not dominant as the hypertrophic cardiomyopathy is. So this is the least common of all the forms, the one that we'll probably see the least. And the other weird thing about this type of cardiomyopathy is that the structure of the heart doesn't change. So with dilated cardiomyopathy, what happens to my heart? It enlarges all four chambers. With hypertrophic cardiomyopathy, what happens to my heart? The chamber size decreases because I have muscle enlargement. Absolutely. With restrictive cardiomyopathy, however, the heart doesn't change size or shape. What happens is the muscles that are present become stiff and hardened, either because of reaction to radiation therapy or because of the deposits that your body has created with amyloidosis, sarcoidosis, or hemochromatosis. The body's depositing things into the cells that make them stiff. But the muscle and structure, or the structure of the heart doesn't change. It's a little bit weird. The other weird part about this is with dilated cardiomyopathy, we lose filling. We lose the ability to contract. Dilated, we lose the ability to contract. With hypertrophic, we lose the ability to fill. With restrictive, we don't really lose the ability to fill, but the compliance of the heart changes. So the heart can fill, but it's just going to be more difficult for the heart. The chamber sizes don't get any smaller like hypertrophic. The hypertrophic cardiomyopathy, the chamber size gets smaller. And the contractility goes up significantly. But with restrictive cardiomyopathy, the chamber size don't change at all, but it's going to be harder to get those chambers to stretch and enlarge to allow more blood into it. So there are two hemodynamic changes that we see with hypertrophic cardiomyopathy that help us identify it. The first change is seen in the ventricles, and it's called the square root sign. The second change we see are in the atria, and we call it the M sign. Now, restrictive cardiomyopathy affects all four chambers equally, especially the ventricles. The biggest effect are seen in the ventricles because they have more muscle. But it affects all chambers equally. So with hypertrophic cardiomyopathy, we saw the change in the ventricles themselves. It dilated, we saw it in everything, but mainly in the ventricles. In the restrictive cardiomyopathy, we're going to see a change in the atria and the ventricles. The square root sign occurs because during the diastolic filling period, the muscle cannot stretch. And because of that, diastasis occurs early. What is diastasis?
The pause where like it's equal in both chambers.
That's right. It's a pause in filling because the pressures in both chambers are equal. And that usually occurs late because as the ventricle fills, what can the ventricle normally do to keep it filling? It can stretch. As it's filling, it stretches. But with restrictive cardiomyopathy, I don't have that. So we get this very strange thing in both ventricles. It happens in both ventricles at the exact same time. We have this square root sign where it fills very rapidly and then diastasis kicks in and we have a long diastasis. So it looks like a square root sign. Normally what we should see happen in the ventricle is we should see that pressure slowly increase until the atrial kick with a small section of diastasis right about there. But with the square root sign, the ventricle fills and it can't stretch anymore, and so boom, we have diastasis. And it looks like a square root sign. The purple color is what is supposed to happen. And we will see this in both ventricles simultaneously. So this is another situation in which two transducers or two manifolds would help, because I could have a manifold hooked up to my pigtail catheter in my left ventricle. I could have a manifold hooked up to my Swan-Ganz catheter in my right ventricle, and they will both be doing this at the exact same time. Matter of fact, their diastolic pressures may actually be almost equal. So here's my right ventricular pressure waveform. They will both show signs of diastasis and the square root sign. Okay. They both will show the same sign. Okay. It's called the square root sign. It's only seen in restrictive cardiomyopathy. And in order to have a true square root sign, you have to see it in both the right and left ventricles. Not at the same time necessarily. I mean, if you see it doing the right heart, and then you also see it doing the left heart, there's a chance that they might have it. Okay, so you can actually see this diastasis occur, the square root sign. Now the second thing that we see is in the atria. And again, both atrias will show the same sign. It's called the M sign. Now, normally we have an A wave, a C wave, and a V wave. A, C, V. A, C, V. Kind of like that. That's normal. That's what we would expect to see. And sometimes the C wave will, join with the A wave a little bit closer, depending on how the heart rate is. The C wave and the A wave can be really close together. That's normally what we would see. Now when we have restrictive cardiomyopathy, we get this thing called the M sign. And it's called the M sign because of how the atria and the ventricles fill. Okay? I'm going to show you a picture of it here. So this is the M sign. Here's my QRS complex, so this is my V wave. You'll notice that the Y wave is quite impressive. The Y wave is quite deep, and then the X descent is quite shallow, creating a M appearance. And the reason for this is that the ventricle fills primarily through passive filling, and then when the atria contracts, it can't really contribute any more blood to it. So we have this thing called the M sign. And it all has to do with how the ventricle is filling. So we have a square root sign. So this is how things should normally look. This is the square root sign. The pressure goes up and flattens out. 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 The pressure should look more like this. Now, there is something that's strange with restrictive cardiomyopathy. So we have these two signs. We have the square root sign, and then we have the M sign. The one issue that we have is there is a pericardial disease that reflects this very closely. There's a pericardial disease that is almost exactly like the restrictive cardiomyopathy. They will actually show the same signs. And so the question comes up, how am I going to differentiate these two? So what does constrictive pericarditis mean? That means the pericardial sac around the heart hardens. And again, it also is caused by radiation therapy. So remember the pericardial sac around the heart should stretch a little bit? Well, with radiation therapy, that pericardial sac can harden. It's almost like the, I'm trying to think of something, almost like an eggshell. It becomes very, very stiff and hard. So as the ventricle tries to stretch, what will the pericardial sac do? It won't let it. It's too stiff. And because of that, the pressure changes that occur in the heart are just like restrictive cardiomyopathy, because what happens with restrictive cardiomyopathy? When it tries to fill, the ventricle can't stretch. And so these two look exactly the same at first. When we do restrictive cardiomyopathy and constrictive pericarditis, they may look exactly the same on our monitors. So we have to come up with a way to differentiate them. And they're treated significantly different. Does anyone want to take a guess of what we do with constrictive pericarditis? Some pretty cool surgery. Not a centesis, because I would drain it. This is the pericardial sac itself.
Remove the pericarditis?
Yeah, what they do is it's an open chest surgery, it's a thoracotomy. They cut open the chest and they peel the pericardial sac like an orange. They just peel it away like an orange. It's that stiff. They make a cut and they just peel the pericardial sac away like orange peels. And then the heart goes back to normal working. Whereas with restrictive cardiomyopathy, that wouldn't help. So we do something called a fluid challenge. So we're gonna give them a fluid challenge test, usually about 10 to 20 cc's of fluid, and we see how their heart handles it. If it is pericarditis,
How are they giving the fluid?
you can either do it a bolus directly into the heart, or increase the IV and just let the IV flow. It just depends. And what happens with that fluid challenge, if it's restrictive pericarditis, the square root signs will stay the same, except the LV pressures will start to rise, but the right ventricular pressures will not with restrictive pericarditis. The LV pressure diastolics go up, the right ventricular diastolic pressures remain the same. Whereas if it's restrictive cardiomyopathy, both of these pressures will go up equally. So what we do is if we have a patient with square root sign and the M sign, and the doctor says, well, what do you think? Is it restrictive or is it constrictive? Restrictive cardiomyopathy, constrictive pericarditis, which one is it? We give them a fluid bolus. If the left ventricular diastolic pressures and only the left ventricular diastolic pressures start to elevate, it is constrictive pericarditis. If both right and left ventricular diastolic pressures start to elevate, then it is restrictive cardiomyopathy. And that's how we differentiate the two. Okay, so with the cardiomyopathies, here are the hemodynamic findings with each of them. With dilated cardiomyopathy, we see the diastolic ventricular pressures rise. We see a decrease in the DPDT contractility, and we also see pulses alternon start to form in severe CHF when they get into severe congestive heart failure. With HOCM, we see pulses by spherins, the double pulse. The intraventricular gradient, where as we pull back the pigtail to the ventricle, we see the systolic pressures drop. And we see Brockenbrough's sign, which is when we have a PVC, what occurs after the PVC is the arterial pressures drop instead of elevate. With restrictive cardiomyopathy, we're looking for the M sign in the atria due to ventricular filling dysfunctions, and the square root sign that we see both in the right and left ventricles. What is the best way to diagnose these three, by the way? Echo. Could we do a biopsy on these? You could. There are two of these that a biopsy may be helpful for. Which two would a biopsy may be helpful for? That we'd actually probably find something to tell us what's going on. And what? Yes, these are the two that a biopsy would be able to, you can look at the biopsy sample and we can see the thickened muscle tissue with HOCM. If you take a biopsy of RCM, a restrictive cardiomyopathy, we can actually see the amyloids or the sarcoids or the hemochromatosis occur in the cell tissue. With dilated, most of the time, if you go back to that our biopsy section, most of the time when we do a biopsy on a dilated cardiomyopathy, it just shows us diffuse damage in the myocardium, which is non-specific. It doesn't really give us a lot of information. So we're gonna go back and do just a quick review and talk about something new here. So again, here's what we see in dilated. Diastolic pressures of the ventricles go up, wedge pressures, pulmonary pressures will go up. Increase in right heart pressures, decrease ejection fraction, which will be our DPDT. These patients also remember dilated cardiomyopathy and hypertrophic cardiomyopathy. Both of those patients can develop mitral regurg. Now, dilated cardiomyopathy treatment. When you first enter to dilated cardiomyopathy, our treatments are going to be medication. What will digitalis do? Let's go back to our pharmacology class. What does digitalis do?
Contraction.
Increases contraction. How? Calcium channels. What about?
They open for long period.
Yes, digitalis causes the action potential to change because it opens, it keeps the calcium channel gates open longer. So this has two benefits to us. One, the more calcium I get in, what happens to my contraction? More, remember I need calcium for contraction. Also, if I keep the calcium channels open longer, what can my cell not do? It can't reset itself. So if it can't reset itself, what happens to the heart rate? If it can't reset itself, it would have to slow down because it can't reset. And so what happens is my heart rate slows down, so what happens to my Frank-Starling's law? It increases because I'm going to have more time to fill. If I have more calcium channels open, what happens to my contractility? It increases. So I feel better and I contract better at a slower rate, and therefore I should have a better outcome. Digitalis is great for dilated cardiomyopathies. Why am I giving them diuretics? Get rid of the extra fluid. My heart is dilating. That means it can't it can't deal with the fluid it has. So if I dry myself up a little bit, it won't cause that dilatation to get worse. It decreases the volume overload. Why would I give them an ACE inhibitor? What is that used to treat? Yeah, it's part of the renin-angiotensin. It's the angiotensin converting enzyme inhibitor. So what's that going to do? What's that going to do to me? What physiological effect will that have?
Get rid of the.
Some of it will get rid of fluids, but something else. This is something else happening in your body.
No,
Say that?
sympathetic.
It's not so much the sympathetic nervous system, but it has something, there's a part of the sympathetic nervous system that is active right now. Angiotensin 2 is a constrictor. So if I block angiotensin converting enzyme, I can't make angiotensin 2, so my vessels will be forced to do what? To dilate, which decreases resistance, which means my ventricle will be able to do what better? Contract and, well, not fill, because I'm decreasing resistance, so it's gonna empty better. Beta blockers. My heart, remember, this is something we talked about in pharmacology. The heart gets overwhelmed. When the heart starts to dilate, the body just overwhelms it with neurohormones saying contract harder. And so what we do is we block some of those signals and the heart can finally start to respond. The heart gets overwhelmed with neurohormones, so the beta blockers kind of helps the heart reorganize and get a better contraction. And then the nitrates are just there to dilate the veins so I have less venous return. You know, you might say, well, that's bad, but on a patient with dilated cardiomyopathy, the less blood is returning, the less volume overload my heart will have. So the whole idea is to get rid of the overload of my heart, increase contraction, increase contractility. Why would I give these patients aspirin and Coumadin?
To stop clotting.
Dilated cardiomyopathy patients have a high risk of clot. The heart is so enlarged, the blood moves so poorly that the blood will start to clot. And so we want them on heparin and Coumadin, so that, or aspirin and Coumadin, not heparin, aspirin and Coumadin to prevent that from happening. We talked about resynchronization therapy. What is that?
Just have your both your ventricles contract like
And what device do we use to do that? Talked about it last week. What device do we do for the resynchronization therapy?
That's fine.
it has like 3 ports.
Yeah, it has three leads into it. You're there. It's a biventricular pacing. It's a pacemaker that has a lead in the atria and both ventricles, one in the right ventricle and one through the coronary sinus, and it gets the ventricle to contract at the same time, increasing contractility. There is a fourth option if it gets bad enough. What is the fourth option for treatment? The only true therapeutic treatment, actually there's 2 therapeutic treatments. What is the fourth option? No, that's the resynchronization therapy. Transplant or an LVAD. Transplant or a left ventricular assist device. That's it. When you get bad enough, these medications, these therapies, even resynchronization therapy will not work. And they will need a transplant, or if they can't get a transplant, they'll be given a left ventricular assist device. An LVAD. What is your chances of getting a transplant? Very low. We don't have enough healthy hearts and we don't have enough people donated organs. An LVAD is an electronic pumping system. And it used to be if you were put on an LVAD, you stayed in the hospital until you got a transplant. But since transplants are so limited right now, LVADs are put into you and you can go home on them now. The problem is if you're put on an LVAD, you probably won't get a heart. So there's two different categories for patients when they get bad enough. Patients who will get a heart and we'll put them on an LVAD for a short period of time waiting for their transplant. There's some patients we know we will never transplant, so they just get an LVAD. a left ventricular assist device.
Is there something like where you can't measure blood pressure?
Yeah, you don't, once you're on an LVAD, you don't have a blood pressure anymore.
Yeah.
You don't have a
Something
pulsatile
like
pressure
that.
anymore. And we'll talk about that actually tomorrow, but LVAD, left ventricular assist devices, if you're put on an LVAD and you're not on the transplant therapy, when the LVAD goes out, guess what happens?
You die.
You're done. That's right, you're done. Okay? If the LVAD goes out, you're done. You're not gonna get a transplant. Whereas on the other side, you're gonna be put on an LVAD in for a short period of time, hoping for a transplant. So there's two different arms now, and we'll talk about that more tomorrow. Hypertrophic cardiomyopathy. There is something we can actually do to treat this in the cath lab. It is called a alcohol septal myopathy. Just missed what's going on. Why aren't you enlarging?
You double click on it.
I don't know what's happened. There we go. There we go. This is an alcohol septal ablation. It is not commonly done. We don't do it very much anymore. I don't know if anyone in Tampa does do it. It was a big thing for a while, but it's a little bit risky. So what we're gonna do is we're gonna actually inject, and it's only used for hypertrophic obstructive cardiomyopathy, so it's only used for when the septal wall is thickened. I'm gonna give you a brief rundown, but this video is on the module. What we're going to do is we're going to do a coronary angiogram, and we're gonna find the first septal perforator. We're gonna go into that first septal perforator with an angioplasty balloon, and we're gonna inflate the angioplasty balloon. Are we fixing the first septal perforator? No, we're not there to fix it. Why are we inflating that balloon? Well, I'll explain that in a second. We inflate the balloon, we're gonna test, we're gonna inject contrast down, just a little bit of contrast down that balloon to make sure there's no leakage around that balloon. And then we're gonna inject 99% isopropyl alcohol down that balloon. What does alcohol do to all biological tissues? Kills it immediately, destroys it. So what we're doing is we're injecting alcohol down this balloon into that septum. And what will it do to that septal muscle? What does muscle do when it dies? No, it thins first, remember, it thins and then scars. So by injecting that alcohol ablation, we have this huge, we have this huge septum, right? And if we inject alcohol into that septum will die, and as it dies, it atrophies and shrinks. And then what has happened to my obstruction? Bad news. It's very dangerous, because if any alcohol leaks around that balloon, as I'm injecting it, if any alcohol leaks around that balloon, where's that alcohol gonna go? Down the LAD, and it will kill anything it touches. That's why we inject contrast first, to make sure there's no leakage. The other problem with it is it hurts like heck. You're causing an immediate myocardial infarction, an intense myocardial infarction within seconds. So it's extremely painful.
You say the heart doesn't have nose, but how do you feel?
Because it's releasing those chemical receptors that trigger the pain receptors. That it feels like you're having a heart attack. It'll trigger the exact same pain receptors that the heart attack does through the same chemoreceptors. So it is extremely painful. Does it work? Yes, it does.
The catheter-based treatment performed to reduce the thickening of the heart muscle, specifically the ventricular septum. During this procedure, the femoral artery is accessed, and a catheter is advanced from the leg until it reaches the coronary artery, supplying blood to the thickened septum. Once the catheter is properly positioned in the septal artery, a tiny balloon at the tip of the catheter is inflated, blocking blood flow. 1 to 2 cc's of absolute alcohol is then injected through the catheter and into the septal artery. The alcohol directly damages the heart muscle, which, over the course of several weeks to months, will reduce the thickness of the septum. By thinning this area, the mitral valve will not move toward the septum, eliminating obstruction to blood flow. This restores the pressures in the heart to normal, resulting in a significant improvement or elimination of heart failure symptoms. It can take several weeks to months for the septum to completely thin and the full benefits of the procedure to be felt.
Pretty cool, right? That's pretty cool that we can do that.
Only if the person has a really long first.
You have to have a big enough first septal. That's right. You have to have a big enough first septal. So we have to rule that first. And it's not an immediate relief. This patient, it takes months of cardiac rehab. They'll have to be put on cardiac rehab therapy. The other concern we have is we can't really control how much myocyte is killed. So there is some concern of overthinning the myocardium and creating a septal defect or a hole in the heart. There is a risk of that as well. So there's some risks with this. And because of that, that is not the common way to treat it. My student, she was offered, I told you I had a student with hypertrophic cardiomyopathy, and they said, well, here's the two ways we can do it. We can do it the septal ablation way, but the septal ablation, alcohol ablation, hurts, and you're not going to, the treatment takes longer to take effect.
Is this
The
something
other-
that you-
what's that?
Is this something that you would pre-medicate them for, so you know you're going to induce pain?
You can't put them totally out though.
But you can kind of
Yeah,
prepare
you
for
can,
them,
you
like,
can, yeah, you
this
can
part
sedate them, you're gonna
hurts,
sedate them heavier, but it,
Not.
and
deep
even
sedation.
after you're done with the ablation, it still hurts. Because remember, that process takes a while for it to go away.
Are there EKG changes with
Yep,
that?
you'll see the ST changes as you infarct it, as you inject the alcohol, the patient will have ST elevation in anterior and septal walls.
Okay.
So the V1, V2, V3, V4, you'll see ST elevation. That will all happen right there as you're injecting. So what is the other option? The other option is a surgical myomectomy. And this is the surgical route.
Septal myectomy is a surgical procedure performed to relieve obstruction by reducing the thickening of the heart muscle, mainly the ventricular septum. During this procedure, an incision is made in the chest to access the heart. The heart is stopped, and a heart-lung bypass machine takes over the work of the heart and lungs. An incision is made in the lower aorta in order to visualize the ventricular septum through the aortic valve. Then, under direct visualization by the surgeon, a portion of the septal wall is resected with special instruments.
It's a little knife
This
that they
widens the
slide
upper
down
area,
and cut that
which
muscle off.
prevents the mitral valve from making contact with the septum. By successfully eliminating the obstruction to blood flow, the pressures in the heart are returned to normal, and limiting symptoms from HCM are dramatically improved or eliminated. Relief of obstruction is seen immediately. However, it can take several weeks to months to recover and feel the full benefit of the surgery.
Okay, so that's the only other way. The only other way is the thoracotomy, opening up the aorta, and it looks like a little, it's almost like a butter knife looking thing. That they open up the aorta and they peer down, they see the valve that's open, and they slide it through the aortic valve, and then they cut they just can visualize cutting straight down that muscle wall, and then they take forceps and remove that muscle tissue, and you have dissected it, and it will close up.
Doesn't
And
it
heal over.
knock and form like a scar or something?
It forms a scar too, it won't clot, but it forms a scar.
So doesn't that obstruct again?
Nope, because a scar does not continue to grow outwards. Remember, this is a genetic malformation that causes the muscles to continue to thick. Scar does not do that. So this would scar over as well.
So it won't thicken again?
Nope, generally no. Is there a slight chance if you lower on? Possibly. This is considered the best therapy. So the problem with this one though is your recovery time is longer. You're in the recovery longer. Because they do a thoracotomy, you're in the hospital longer. You feel the effects almost immediately, unlike a alcohol ablation. Alcohol ablation, you usually go home the next day. With this, you might be in the hospital a little bit longer because they did a thoracotomy and a incision, and they also had to resuture the aorta up, so they want to make sure that there's no internal bleeding and things like that. So, people are saying, well, which one is better? Well, that's hard to say. My student chose the myectomy one. And she said it's instant relief of the symptoms. Yes, you're in the hospital longer, but it takes less time to see the effect, and it's under more control. You don't have to worry about that alcohol leaking out to another vessel. There's more control with the myectomy device, with the myectomy process.
Cause a problem with conduction.
It could, if you cut too deep, or if you cut it, it can cause left bundle branch block. It can do that. So that is one of the risks that they would talk to you, that they would clear for it. But so could the septal ablation. The septal ablation could kill off the muscle tissue and also kill off if it's too much, could kill off that left bundle branch. So either way, there is a risk of the left bundle branch being damaged.
It's more controlled to do the septal myectomy, because you know.
You know how deep you're going, whereas with the ablation one, you don't know exactly how far that's going to penetrate into the muscle tissue. So she went with the myectomy, and she felt that was the best option for her, and it worked out very well for her.
You think a muscle will go back up again later?
Not generally, no, because it's scars.
Okay.
Because your body will replace it with scar, generally. Now, I believe there is some case studies that say that there could be a little bit of hypertrophy that occurs, but it should not, because of the scarring, it's scar rather than muscle tissue. Because you don't grow new muscle tissue. So once you cut that new muscle tissue away, the only thing that will grow there is scar. But the rest of the muscle tissue could still continue to hypertrophy slightly, but you've gotten rid of the large bulge. There is an alcohol ablation live case study for you to view, where they're actually doing an alcohol ablation. They like to do it with ultrasound. So the reason why they like to do it with ultrasound is they can actually see the hypertrophied muscle directly, while we can't see it under X-ray. So right now,
They can still put the hemo on the right side below.
so they're trying to make sure they're at where they're at. They're injecting the alcohol here. They don't show you an EKG. There's another one that shows an EKG, but.
The last one was RV dysfunction, the tricuspid valve.
So he goes through, and they actually have a little bit of a difficulty on this one. I can't remember what.
Functional patient, I would argue that with a really good septal ablation, you could.
And the pressure they look at the pressure changes, and they look for an interventricular pressure change, and it actually is only slight.
50%, but, great demonstration.
So they take, and you can see that the muscle does change here if you look at it before and after. There's this video here that shows them how to do it. Not done very often because of the complication it has with the patient. Now, no reason really to transplant a hypertrophic heart. There's other ways to take care of it. Medication-wise for the hypertrophic heart, does anyone want to take a guess of what medications we might put them on? Remember, the biggest problem is their contractility is too strong. What medication might we put them on? Beta blockers, that's right. Beta blockers are key therapy to hypertrophic patients. We don't want them on digitalis because that's going to make it contract harder. So instead what we do is we put them on doses of beta blockers to allow the heart to not contract as hard, to suppress the contraction. So beta blockers are the key. Then we come to restrictive. So with dilated, we have lots of drugs, we have resynchronization therapy, and transplant or LVAD. For hypertrophic cardiomyopathy, we have beta blockers at first, and then myectomy or septal ablation. Restrictive cardiomyopathy. Can we transplant a restrictive cardiomyopathy patient?
No,
Why not?
because primarily genetic and not autoimmune.
And so once we put a new heart in, what would happen to it? Same thing, you'd waste a heart. So restrictive cardiomyopathy patients, except for rare occurrences, cannot get a transplant. The therapies for restrictive cardiomyopathy patients are to try to treat the underlying condition, the amyloidosis, the sarcoidosis, the hemochromatosis. The bad news is there a great way to reduce those? No. Anti-inflammatories, steroids, things like that. If it gets severe enough, there's not much we can do. We try to manage the symptoms associated with heart failure, because these patients will, again, go into heart failure. What type of heart failure will these patients have? Forward or backwards failure? Backwards, because the heart can contract, it just can't,
Push.
you know, it can't stretch, it can't dilate. So these patients get backwards failures. We're talking about treating pulmonary hypertension, we're talking about treating ascites, getting fluid off the body. It's really hard to treat restrictive cardiomyopathy, which is why it's good that it is the least common form. It's really treating the underlying cause, not treating the heart itself. There's not much we can do for the heart itself. I have a friend who has scleroderma, and she now has cardiac effect, and she's having more and more cardiac problems, and the problem with that is that there's nothing the doctors can really do about it. So they try to treat her with steroids and things like that, but with the understanding that it's probably gonna get worse. There's not much they can do for her anymore. So those are the unfortunate ones. So that is the cardiomyopathies, okay? The keys that you wanna know is what they are, what causes them, how are they different from each other, what causes them, what are the hemodynamic findings that we look for, what do we try to, when we're trying to diagnose them in the cath lab, what pressure findings do we look for, and what are the potential treatments, okay? So what are they, what do we look for, what are the signs that they have it, what causes them, and how can we treat them? And in the cath lab, we can treat hypertrophic, but the rest of them we really can only be there to diagnose and say it's getting worse or better. Okay, that is enough for today. We will take a break, and when we come back, we will talk about blood gases. Blood gases, blood gases, blood gases.